Hi, I'm Dr. Dan Rubin, and welcome to another episode of Ad Hoc with a Doc. We're honored to be here with Dr. Larry Bands, who I've known for many years here. Dr. Bands is a urologist and urological surgeon, retired of course now, but actively back into consultative practice, at least somewhat. We're going to talk today about his specialty, which is prostate cancer. Prostate cancer decisions, especially when somebody's diagnosed, can sometimes be difficult to make. There just seems to be so many options out there. And I think even though there's been so many books written about this to help educate the public, it still seems daunting to a lot of patients. I know a lot of people come see me and they ask me questions, and some I'm not qualified to answer for them, but I can still help educate them so they can make their best decision. You've been around in medicine for quite a while. You're a surgeon, you've seen the prostate, you've taken them out, you've helped people make decisions. Would it be okay if we sort of started at the base, which is prostate cancer screening?
Sure, absolutely.
Have you seen changes in your career related to prostate cancer screening?
Yes, I started in the 80s, came to Phoenix in 1983, joined a urology group.
Interesting.
Worked my way up with the group, and we ended up growing the group to a very large group, which has now merged with other groups. I spent 20 years with them, Urology Associates.
Okay.
And when I started out in the 1980s, there was no PSA blood test. Most people were diagnosed late with prostate cancer. Most people, the majority.
What does late mean?
Late means that the cancer had already spread
Outside the prostate. Okay.
And was basically incurable at that point.
So you couldn't really do surgery to cure?
Correct.
Okay.
Correct. Now there were some people with examinations, we call the DRE, digital rectal exam, where cancer could be picked up early and organ confined or localized to the prostate and be cured with surgery or radiation. But a significant percentage of people back then presented with metastatic disease where the cancer had spread to bone and other parts of the body.
Okay.
Around 1990, the PSA blood test came about.
Okay.
And people started getting screened, and the higher the PSA level, the higher the risk of having prostate cancer.
Now, Dr. Bands, what exactly is PSA?
PSA stands for prostate-specific antigen. It is a protein that's elaborated by prostate cells, both benign and cancerous cells, and it's a blood test. So people would simply have their blood drawn. You would measure the amount of this protein, PSA, in the blood, and we found back then, 20 to 30 years ago, that if it was elevated, then there was a higher risk of having cancer, and we went ahead and did biopsies on those patients.
Okay, very good. Meaning that normal prostate cells that are not cancerous do produce PSA.
Correct.
But the higher it went, the thought was that these cells were growing or there was something wrong with them and they were producing too high of numbers, and hence the screening exam, and then you would biopsy.
Correct.
Good. Okay.
Yeah. And for some reason, cancerous cells tend to seep more of this protein out into the bloodstream.
Okay.
So what happened in the 90s was that we detected a lot of early prostate cancer by PSA blood test screening and by biopsies.
It sounds like you were saving lives.
Yeah, and we did actually decrease the mortality rate of prostate cancer. It became controversial within the past 10 years or so because we got really good at detecting prostate cancer. We began detecting people who have very early stage disease in the prostate. And when we do that, we have a dilemma, and this is where part of the controversy has come in terms of screening. If we pick up prostate cancer at a very early stage that may not harm the patient in their lifetime, then the problem is some of the treatment options may be more harmful to the patients
than the disease.
Than the disease itself.
Hang on for one sec, because this is a really big concept, and to some people may be confusing. You're saying that people can have cancer in their prostate, but it may not actually be aggressive or bad enough that they may not die from that disease?
There's no question about that. I mean, statistics show that about 30% of 50-year-olds in America harbor microscopic prostate cancer.
Wow.
By the time you're 60 or 70, it's 60 to 70%.
Of people, of men.
Of men.
Interesting.
If you live to be 100, you're almost guaranteed to have microscopic prostate cancer. So the dilemma here is that currently about 1 in 6 men in the U.S. get diagnosed with prostate cancer in their lifetime.
Okay.
However, only about 1 in 36 men die of it. So there's an awful lot of people who do not need treatment, who live with the disease, and it doesn't kill them.
So it must be difficult for some men to make the decision on whether or not they treat, or maybe have what is referred to as active surveillance, just to make sure that things don't get out of hand. Part of what you do now is help people sort out those decisions, I understand.
Yes, that's correct. You mentioned that I was retired partly.
Yeah.
A couple years ago, I stopped operating for prostate cancer. And I did that for a number of reasons. I did it so that I could be purely objective with patients. I might want to add that I'm a prostate cancer survivor. In my 40s, I started checking my PSA, and by age 50, noticed that it had bumped up a bit.
Okay.
And went into my office one day and asked one of my partners to biopsy me, and he just said, "Are you kidding me? This is ridiculous."
Right.
I said, "No, I think I have prostate cancer." So he did, and I was diagnosed at age 50. So I've been there, I've been through the treatment, but part of the dilemma today is the fact that the U.S. government, the U.S. Preventive Task Force, has downgraded PSA screening and PSA blood testing.
Okay.
And they
What does that mean, downgraded?
Well, the problem is that PSA testing is not specific for prostate cancer.
Oh.
There are other abnormalities of the prostate that will raise a PSA level in the blood. And so because it's not specific for prostate cancer, we tend to biopsy more people than we might need to.
And that can maybe cause harm or complications?
Oh, definitely.
Okay.
Yeah, biopsies are not totally benign. There's risks of infection and bleeding and other issues.
Okay.
So they've told the primary care physicians in this country and other physicians that they think we probably should not be screening people. That is a real dilemma here.
Could we repeat that again?
Yeah, the U.S. Preventive Task Force in 2011-2012 era.
Okay, so about 6, 7 years ago.
Yeah, they came out and they outright said that people in this country should not be screened for prostate cancer with PSA testing.
Interesting, but it doesn't seem like it's stopped. I still see people being screened for the most part.
Well, it did decrease the amount of people that got screened. One of the problems was one of the U.S. studies to try to prove whether or not screening saved lives was a 10-year study.
Okay.
And that 10-year study was not definitive in saying that it was a life-saving screening modality. The Europeans, on the other hand, have continued screening, and they have found in their screening tests that it saves about 20 to 30%. There's about a 20 to 30% reduction in mortality or death from prostate cancer in men who are screened.
Interesting.
So we have a dilemma here. In this country, the government has said screening doesn't seem to save lives. In Europe, it does. And now additional studies in this country suggest that it does.
Well, that it does.
That it does. In the meantime, there's a lot of doctors and a lot of people, and the press has been on this and said we shouldn't be screening. And there's consequently a lot of patients who are going without screening. And unfortunately, I mentioned earlier that in the 1980s, a lot of people were diagnosed with advanced incurable disease. We've seen a rise in that in the last 3 or 4 years because people have stopped screening.
Got it. Understood. Dr. Bands, once somebody is diagnosed with prostate cancer, they've had their biopsy, what then? Because I know that there's different ways to grade it. There's something called the Gleason score, which is when the pathologist looks in the microscope and assigns a certain numerical value to describe how aggressive the cell looks or how aggressive the prostate cancer is. If you could tell us a little bit about what options people have once they've been diagnosed, and then what the differences are in the grading, or what the grading system means, per se.
Okay, sure. Well, the grading system is just, it's an effort by the pathologist to try to tell the doctors, the clinicians, and the patient how aggressive the cancer might act. A low-grade prostate cancer, for example, a low Gleason score, which today the lowest grade for the most part is a Gleason 3+3, a total score of 6.
6, okay.
A lot of those patients have what we call indolent disease. It is highly unlikely to spread in their lifetime.
Like to the bones or to the lymph node or to another organ distantly.
Correct.
It would stay inside the prostate cancer.
Correct.
Okay.
And consequently, over the last 15 to 20 years, there have been a lot of studies throughout the world. The biggest one is in Canada, where people have looked at people with low risk or low grade disease or low Gleason scores, and they've asked people to do what's called watchful waiting.
Okay.
In the past, it's now called active surveillance currently. And we've monitored these people with close follow-up to try to determine if they really need treatment or not.
What type of follow-up would occur in active surveillance?
Active surveillance would typically be relatively frequent PSA blood tests, usually on the basis of 2 to 4 a year.
Okay.
Physical examination, the digital rectal examination, and just patient monitoring over that time period. Yes.
If they have pain or if they have any changes in their urinary status.
Yeah, although some of those things may be late in the disease course.
Okay. Interesting.
And we found basically that the mortality rate, the death rate from low risk, low grade prostate cancer within about 15 to 20 years is exceedingly low if they are not treated. Now the dilemma here is that, number one, people can have low grade disease at one point in time, and in subsequent years they may advance to higher grade cancer, or they may develop what we call de novo higher grade cancer.
What is de novo higher grade cancer?
That means that someone may be living with a Gleason 3/3 cancer, the low grade cancer, and all of a sudden they show up with a higher grade.
How would one know that? Would they have to get another biopsy?
Correct.
Okay, and that would be a decision made between their clinician and themselves and for good reasoning.
Correct. Now, not always do they need a biopsy. Sometimes prostate MRI scans today are highly effective at suggesting whether or not someone has what we call intermediate or high-grade prostate cancer. So some of these active surveillance protocols are incorporating scanning into the follow-up plan. And we went from a situation a number of years ago where we recommended annual repeat biopsies to people to a point where at this particular point in time, I'm recommending that a lot of people have repeat biopsies in a 3 to 5 year range rather than annually.
And the reason to have the repeat biopsies is what?
Well, biopsy still is the only way to tell whether or not someone has cancer and what grade it is.
Got it. And Dr. Bands, can somebody have 2 different Gleason grades within the same prostate organ?
Well, the Gleason score, it's a complicated question. The Gleason grading score has 2 numbers in it. The first number is what's called the predominant pattern, and the second is the secondary pattern. So there are a lot of people who have 2 or 3 different patterns. And that if someone has what's called a Gleason 3, the lowest grade, and a Gleason 4 in their prostate, the pathologist calls that a 3+4 or a 4+3, depending on the percentages. So the answer to your question is yes, people can have Gleason, they can have higher grade and lower grade cancer in the prostate.
And then generally is the highest grade the one that's focused on and treated?
Always. Yeah, you always want to look at the highest grade because that's the more serious pathology.
And Dr. Bands, we talked about Gleason of 3 + 3 = 6. We just mentioned 3 + 4 = 7. What happens once the Gleason grade goes up? And what you talked about a 6 and what somebody's life expectancy may be or their mortality. What happens if somebody is at a 7 or an 8?
Yeah, so then they're what we call intermediate or higher risk for potential of spread. And if prostate cancer today spreads outside the prostate, it becomes a potentially life-threatening situation. Not always, but in many cases. So the higher the Gleason score, the higher the grade, the higher the risk level that it might spread dictates what best is decided upon in terms of treatment options.
Got it. Are there prostate cancers that produce little or no PSA?
Yes, they're rare,
Okay.
but the really high-grade prostate cancers, the one that we call more poorly differentiated cells
Okay.
that have lost their normal prostate function, those cancer cells might not produce much PSA.
Got it.
So there are some people with very aggressive cancers that may actually have low PSA.
And so PSA isn't necessary, or is in those situations is not a good marker for them. You need other types of diagnostics or screening tools. Do those people generally present with a symptom, which causes the doctor to then suspect something and maybe do a scan?
Yeah, those people can present with symptoms, whether it's blood in the urine, difficulty urinating, slower stream, urinary retention.
Okay.
If they're getting frequent annual physical exams, for example, by their primary doctor, if they're doing digital rectal examinations, those are the types of patients that might show up with an abnormal prostate exam
Okay.
and a normal PSA.
Understood. And that yet again complicates things too. I mean, it's a complicated disease is what it sounds like.
Correct.
And what you do now, you talk to people about different options that they have, answer their questions in a truly consultative role. If somebody is now going to move towards treatment, that they have a higher than a Gleason 6, say a Gleason 7, what are the main treatment options available for somebody with, let's say, localized prostate cancer, which has been found not to have spread outside the prostate? And I am going to throw in one other question. There are instances where it doesn't seem like the prostate cancer is spread outside the prostate, but it's maybe broken through its capsule. And if you would be able to comment on the difference between spreading outside the prostate and breaking through the capsule that the prostate is in, so to speak.
Sure. Well, that gets into what's called staging of the cancer.
Okay.
And the prostate, you can consider the prostate kind of similar to an apple.
Okay.
And the skin of the apple is the outer edge of the prostate.
Okay.
It's a pretty good barrier to cancer. There's a lot of cancers that go right up to the capsule inside, but they don't actually grow through the skin of the apple or the capsule and get outside.
What is the capsule made out of? Is it just
The
connective
capsule is
tissue?
just a connective fibrous tissue.
Okay.
Right. And it's very thin, but it's a pretty good barrier in many cases.
Okay.
With aggressive cancers, it can actually grow into that capsule or outside of the capsule.
Is that considered spread?
Yes.
Okay.
So if it actually grows outside the prostatic capsule, the pathologist calls that extraprostatic extension of cancer, and that's a much more serious issue. For example, if a surgeon goes in and removes the prostate and there's microscopic cancer cells that have already spread outside of the prostate, some of those cells might be left behind at the time of surgery. If the patient elects radiation therapy, which is another common treatment option, that area tends to be irradiated very close to the capsule.
Is this without surgery or in addition to surgery?
That's without surgery. So the stage really is based on how advanced the cancer is. If it's through the capsule, if it's into the surrounding area, if it's into the lymph nodes, or it's into the bone or outside the pelvis.
For people that unfortunately have had the prostate cancer spread outside the prostate, there have been many new approved agents that can be used therapeutically for these people. Can you tell us a little bit about those?
Yeah, this has been a new era in prostate cancer treatment in my career. When I started a number of years ago, we had one treatment for advanced disease, and that was hormone therapy. And that was it. We then developed some chemotherapy that was sometimes beneficial in advanced disease. But in the past 7 to 8 years, there have been, at least 7 or 8 new agents that have been approved by the FDA. There's new advanced hormonal agents, many of which can be taken as pills without any significant invasion. There's new chemotherapy that has been shown to be highly effective for improving survival if people present with disease that is advanced or spread. There's new agents like Xofigo, radium-223, that is given for bone metastatic disease.
Okay. Does that help with bone pain too?
It does help with bone pain, exactly. There are other bone strengthening agents like Xgeva and different things which are now in common treatment paradigms for people with advanced disease. And now we're working on new immune therapies, checkpoint inhibitor studies and things like that, which have been proven to be effective with kidney cancer and melanoma and other cancers. So it's a very exciting field right now, and new agents are coming out all the time. There was just another hormonal agent that was just approved for rising PSAs in people who do not yet have evidence that it has spread to the bone, but we know it has spread either to bone or other areas in the body. So this is really the exciting frontier for prostate cancer today, because even if it spreads, even if it's picked up late, people are doing very well with some of these new agents.
Excellent. You said something right there that caught my attention.
Okay.
For somebody that you said something about using these newer treatments, the new approval of the hormone therapy for somebody who doesn't yet have evidence of spread to the bones, but that have spread. Does that mean that they would have a rising PSA or evidence of disease somehow, whether it be a symptom or whether it be a biochemical finding, but you can't yet see it on a scan?
Yeah, that's correct. It's specifically a rising PSA.
Okay.
The PSA rise has to be substantial, and what's called the doubling time of PSA rise has to be less than 10 months.
Okay.
So, and these people have to have been treated for prostate cancer, and if they've been on treatment and their PSA is going up rapidly, even if the scans do not show any evidence of disease, putting them on one of these new agents that just got approved has shown at least a 2-year survival advantage.
Wow.
If it started early.
It's a long time.
So we don't want to wait with a lot of these patients right now like we used to have to do.
Sure.
Getting back to your question though, when you're talking to patients, or when I'm talking to patients about treatment options, so much goes into that decision making. The general health of the patient, the age of the patient, the attitudes of the patient, because all treatment options have some potential risk and side effects. Surgery, for example, there's a small risk of long-term incontinence. There's a sexual aspect of it in terms of erectile dysfunction and sexual dysfunction. Radiation has some potential long-term harmful side effects. So you have to kind of put it all together, and it's a very team approach to trying to decide with the patient what's right for them.
The team being whom?
Well, the team being, at least in my opinion, the consultant and the patient. But what I really value is what's called a multidisciplinary panel of experts, including surgical expertise, radiation expert, medical oncology, alternative medicine, naturopathic alternatives. And I think it's really important for these patients to have access to that type of multidisciplinary plan so they can get a broad range perspective on what their options are and what the side effects might be.
Excellent. And I've heard other patients who have talked about something called cryotherapy or something called HIFU.
Right.
Are these additional options for people in the United States?
They are, and they've been around for a number of years. Cryotherapy, cryo means freezing. So there are modalities where you can actually put probes into the prostate and freeze the tissue. HIFU means high intensity focused ultrasound, which actually burns or heats the tissue. And both the freezing and the heating methods kill cancer cells.
Kill them.
And that's what we want. We want to kill the cancer cells and diminish the potential collateral damage. They're all possibilities today. So surgery, radiation, cryotherapy, HIFU, high intensity focused ultrasound, active surveillance, which we alluded to earlier, are all options for patients.
This is wonderful. And you sit and you can take all those things into account, and as part of a multidisciplinary team, you can help patients make those decisions, what's best for them.
Correct.
Excellent.
Correct.
I'd also like to talk a little bit about the role of imaging. You mentioned MRI. I know, and it doesn't have to necessarily be for localized prostate cancer, because we should also talk about prostate cancer does spread for some men. Can spread to the lymph nodes, to the bone, maybe there's some other areas, the liver. What other type or what types of imaging is available? I know that there's some very specific tests like the C11 test specific to prostate cancer, and you've seen the development of these through your career.
Yeah, I've been very fortunate here in Phoenix to work with Dr. Almeida, Fabio Almeida, and other experts.
Great physician.
Who have really pioneered some of these newer PET scanning modalities. Basically, the imaging question boils down to standard imaging, which used to be just a standard bone scan and a standard CT or CAT scan.
Okay.
MRI.
I'm sorry, CAT scan of
the pelvis or abdomen.
Okay, looking for like lymph nodes or lesions in the bone?
Correct.
Okay.
Or disease that is actually spread outside the capsule.
Got it.
Local
right.
spread.
Got it.
MRIs have evolved lately to becoming, they're called 3T multiparametric MRIs with contrast. And we can now, in many cases, determine whether or not people have the intermediate or high risk prostate cancers based on imaging with MRs. But the newer modalities, when we see people who have been treated, and after treatment we expect their PSA to act a certain way. If the prostate's removed, we hope the PSA goes to an undetectable level.
Okay.
If they have radiation, we hope that it drops substantially and stays low.
Okay.
But if it doesn't, this is another role for a consultant like myself and Dr. Almeida in imaging, et cetera, to try to determine why a PSA is rising after definitive treatment.
Yes.
And so he's developed or been involved with something called the C11 acetate PET scan.
Okay.
It's very similar to what the Mayo Clinic has evolved in Rochester called the C11 choline PET scan. There's an Examen test now, which is called a fluciclovine test. And now Dr. Almeida is working on a PSMA gallium scan, which is one of the newer scans.
And PSMA is a little bit different than PSA, but still around.
Yeah, PSMA stands for prostate-specific membrane antigen.
Okay.
So what we're now trying to target, we're trying to get imaging agents to actually hook onto cancer cells and become detectable with PET scanning and other modalities.
So you can really find them and localize them and know what it actually is that's showing up on the
Correct.
scan.
And if you can find that, if someone presents after treatment with a rising PSA and you can find a specific site of recurrence of the disease, you can potentially treat that effectively with modalities like radiation.
Okay.
So those are the goals that we have these
Wonderful.
days.
It sounds like there's really been advancements in both in determining who is a candidate for treatment, who should be screened, and then what happens after the screening. And it's really clear the importance of the role that you have in a patient's care and helping them make the right decision, especially given all the criteria that you had talked about when helping people make those decisions.
Well, I feel honored to be in that role at this point in time. I encourage men, particularly in the 45-year-old to 70 age range, to strongly consider getting screened. And if their doctors don't want to do it, I think they should move on to a urologist and get a PSA and an exam. And be followed carefully. I have so many patients that have gone 4, 5, 6 years without any testing, and they present with late advanced disease, which is very tragic.
Understood. Well, I wanted to thank you very much for being here. It's been an honor to have you on Ad Hoc with the Doc. I've known you for many years. The work you've done with the patients that I've co-managed with you has been exemplary. And thank you for being here.
I appreciate it. Thank you very much, Dr. Rubin.